In Part B of the module, we will discuss how caregivers support families through the safe storage and handling of breast milk, as well as by having staff trained on infant feeding. Breast milk is classified as a food and does not require universal precautions for the handling of body fluids. Breast milk also does not need a separate refrigerator for storage. This slide can be found on the top of page 4 in your handout. It depicts some useful information about storing breast milk safely. Families may choose to bring breast milk to their child care program, frozen or thawed. If frozen, human milk should be defrosted in the refrigerator and then warmed briefly so that the temperature does not exceed 98.6 degrees Fahrenheit. If there is not time to defrost in the refrigerator, human milk may be thawed by placing it under cool running water. Bottles must be consumed within 1 hour of being warmed or removed from the refrigerator. Warmed formula or breast milk can provide a place for bacteria to grow. It should not be reused. It can be sent home with the family or discarded per your program's breastfeeding policy. Some mothers may request to have the used bottles returned with excess milk in them so they can better send in portioned bottles to reduce waste. Bottles should be individually labeled with a child's name to prevent serving the wrong bottle to a child. Programs should have a system in place to receive bottles each day and assure they are promptly refrigerated. They should not be left in diaper bags for extended periods of time. Bottles should be rotated using the oldest milk first. Ideally, a child's bottles are stored in a way to minimize the possibility of a feeding error. Some programs choose to have individual storage bins in the refrigerator for each child. This is depicted in the picture on the far right of your screen. Some programs implement a color coding system where a child's bottles are marked with a specific color. Bottles not in use should be covered to prevent cross-contamination. Find the fill-in-the-blank activity on the bottom of page 4. The first step before any feeding is to wash your hands. Never microwave human milk, as it can destroy properties in the milk. Warm the milk under warm water or place it in a container of water. Bottle warmers are fine, but crock pots can be dangerous. Infants have received burns from hot water dripping from an infant bottle immediately served after being removed from a crock pot. Crock pots should also be out of reach of children. Toddlers have been burned by pulling the crock pot down on themselves by a dangling cord. To test the temperature of milk, place a drop on the back of your hand or wrist. Do not test milk temperature by sticking a finger in the milk. Temperature should not exceed 98.6 degrees Fahrenheit. Excess heat will destroy properties in the breast milk. Gently swirl the milk and never shake it. As care providers, prior to each feeding, we check labels to ensure that the correct milk is being fed to the child. If a feeding error happens, there are detailed steps to follow from the Center for Disease Control and Prevention. These can be found on page 12 of your handout and the Child Care Health Consultation Sample Policy. If a child should receive the wrong bottle, either breast milk or formula, the mix-up should be documented and the parents informed. The risk of disease transmission with the wrong breast milk is low. The mother who provided the milk should have a blood test to check for communicable diseases, and the mother should share these results with the family of the child who received the breast milk. Staff do not need to be informed of test results, as this is protected health information. Growth spurts can be a stressful time for mom to keep up with the increased demand for milk. If mother and baby were not separated, baby would adapt by nursing more frequently, and within hours or days, mother's milk supply would increase. This can be more challenging if the infant and mother are separated and the infant is in full-time care. You may notice on the slide that a typical growth spurt occurs around 3 months, and this can also be a common time for infants to begin child care if the mother took 12 weeks of maternity leave. Encouraging mothers to keep a small amount of frozen milk at the program can be helpful during growth spurts. Mothers might bring in a variety of portion sizes from 1 to 4 ounces to minimize waste. Many programs have some type of feeding log or activity log, you might call it a daily sheet, in use for their infant and toddler rooms. These feeding logs can help breastfeeding families see when growth spurts are happening or their infants are eating more frequently. They can help a mother prepare adequate portion sizes that minimize waste. It is equally important to communicate verbally with families on feeding plans. Some mothers depend on drop-off and pick-up feedings to keep up their milk supply. Communication daily can support staff in responding to infant feeding needs and meeting the mother's feeding plans. A hunger and fullness cues chart can be found on the top of page 5 in your handout. The best practice is to feed babies on demand rather than on a clock. This is known as responsive feeding and helps prevent obesity as it allows children to understand hunger and fullness feelings. Using responsive feeding, children learn to eat when they are hungry and stop eating when they are full. For breastfeeding mothers, feeding on demand helps maintain an adequate milk supply. The left-hand column lists some typical hunger cues. These include hands moving toward the face, opening and closing the mouth, sucking on the hands, turning on the head from side to side, and finally crying or turning red. Caregivers may be familiar with the rooting reflex when an infant moves its mouth in the direction of something or someone who is touching their cheek. Ideally, caregivers will wait for an infant to display hunger or feeding cues, but will respond before the infant is crying and red. Less experienced caregivers may confuse feeding cues with interaction-seeking cues. Likewise, as caregivers, our goal is to respect an infant's fullness cues and stop feeding. Fullness cues include turning away from the bottle nipple, increased attentioning on what is happening around him or her, keeping the mouth closed, saying no. We may be tempted to encourage the baby to finish the bottle, but this does not support the development of sound eating habits. Best practice is to respect the infant's signals and stop the feeding. Allow the infant to take a break and consider offering the bottle again in a few minutes after a rest. If the infant refuses, stop the feeding. Feeding from the bottle is different from feeding at the breast. Typically, from the breast, milk flows in waves, faster then slower. From the bottle, the milk flow is much faster. Babies may need to pause during the feeding to catch their breath. Babies should be accustomed to bottle feeding prior to beginning childcare. There is not a set time to begin exposing an infant to a bottle, but lactation consultants usually recommend waiting until the milk supply is established and breastfeeding is going well. Some babies will refuse the bottle if they know mom is available. A dad or another caregiver may have more success offering the bottle. Helping baby get accustomed to a bottle eases the baby into the child care routine. The following video captures information on paced bottle feeding. Paced bottle feeding is a technique that mimics aspects of the breastfeeding experience for infants.